to Knowledge on the Go, the podcast brought to you by the PI Programs team at Vizient. Over the past decade, the way we deliver care has evolved. One of the biggest changes is how patients message their care team. These patient portal messages range from simple prescription questions to complex follow-ups. I'm excited to introduce Dr. Ko, Chief of Dermatology Service Line and Associate Chief Quality Officer at Stanford Health Care, to talk about their story behind patient portal messages and its impact on provider workload. I'm Mathilde Hanchard, Performance Improvement Administrative Fellow, and your host for this podcast. Welcome, Dr. Ko. It's great to have you.
Thank you very much. It's a pleasure to be here.
What first drew you to provider workload in the context of patient portal messages, and why do you feel it matters now more than ever?
Fortunately, in my work at Stanford, there's a few different hats I get to wear. Many of those intersect with this challenge. I see patients. I take care of folks with a lot of different issues, from melanomas to psoriasis of the skin to others. What has happened over the course of my 13-year clinical career is the way that we deliver care and the way that patients expect their care to be delivered has fundamentally changed and shifted. Part of that has been to evolutions in digital care capabilities, telehealth. All of this was accelerated over the course of COVID. We still have upwards of 30-40% of our ambulatory visits conducted through video means. So we've been able to carry that forward and do that effectively for our physicians, for our care team members, and for our patients. I look at this asynchronous care channel in our environment. We call it My Health. We haven't figured out how to make this part of our care like we have with video visits. It's sitting on top of the work that everybody does, that our physicians, our APPs, that our care team members do. It's something that we haven't devised the way to integrate into the work. And so it is what we call the work on top of the work. That is a disconnect and imbalance.
You had said that it has grown so much since COVID. I kept seeing it's grown like 157% since 2020. Are your providers feeling that? Are you seeing that in your providers?
We were seeing this growth before COVID. Some of this is just national trends. Some of this are intentional investments that we've made within our health system, where we have been actively investing in this channel and this platform with our patients. At the beginning of COVID, that was 900,000. And now we're about at 1.5, 1.6 million. That is more than doubling and really engaged active users. We also have activity in terms of how they engage with us. We have those refill requests, appointment scheduling, and we also have a lot of activity through that clinical channel. We started with the challenge of how do we talk about this? Are they messages? And then took a step back and we said, what are these that patients are looking to have addressed or get help with? We realized it was an aha moment. So we term them PMIs, for patient medical interactions, and they can be one message, but oftentimes they're back and forth and threads and forwarded messages and getting other people in the loop. Patients are trying to get something clinical accomplished. It's an element of following up on a visit, or they have a new concern or new issue or new flare. If we look at the volume of those, 2017 through COVID exponentially increased. Fortunately, we have reached a plateau in terms of what we see from a volume perspective. Place a great strain on our physicians, our clinical teams, our extended care teams. And that's something that, even though things have leveled off, doesn't mean that problem doesn't exist. Just means that we have a little bit of time to take a breath and say, how do we address this?
You were mentioning work on top of work. You and your team found a way to make this invisible work more visible. How did you go about doing that and quantifying this work? And how does this differ from what's been done in the past?
A lot of boots on the ground effort where hotspots in different places are addressed with individual initiatives. Some people raising their hand and saying, I've got a fire here, don't know what to do. Our ambulatory leadership stepping up and saying, there's an opportunity and there's a challenge here and there's a burden. We have an amazing program led by our chief wellness officer. Through that, surveys on a regular basis of faculty physicians about burnout. This was a hot spot. We were seeing that through data, through stories, through people essentially escalating and saying, this is not a sustainable state where this level of work that is happening that people are feeling but not able to express. This is becoming not just 30 minutes after clinic. This is hours at the end of the day after notes, and then it doesn't stop. Our ambulatory leadership, whether a management guidance team, a group, a dedicated effort that allowed us to just look at individual ground level local solutions, but to understand what is it that we have as a responsibility from a health system perspective, responsibility at an institutional system perspective. How do we resource that, provide them the right visibility? We looked at this from a specific physician perspective, thinking about how do we decrease the burden on our physicians. APPs. One of the first principles was this is not about shifting work from one group to another. This is about how do we optimize it for everybody.
After you were able to quantify this work, what did the data reveal? How did this shift the conversations you were having with your team? And what really stood out or surprised you from what you learned?
Anybody who's done work in this area knows that metrics and quantification around this challenge and problem is incredibly complex. What is the burden of patient messages? One of the first insights that we heard was the volume of them. That is the one message out of 10 that is such a cognitive, logistical burden that I will take 99 of the other ones, but just don't give me that one. There's complexity that we were trying to capture. We did a broad survey and looked to see, is there something off the shelf? The correlation between burden and that number is there. And there wasn't. We tried to quantify how many patient medical interactions are there. Of those patient medical interactions, how many of them require a physician understanding it? What's the number that's being addressed? Of those, what are the ones that are related to an existing visit or an interaction that happened? We wanted to be able to capture that and say, that's related to that thing that just happened, versus the other category, stuff that's happening between visits. This is a new issue, a new concern, a new flare. This is a new diagnosis, a new question. Beyond that, we also wanted to have some idea of how do we understand the intensity or the complexity of the message. We were able to create a system and work through some of our group members. This involved a really close collaboration with our digital health team, where we were able to take the clinical reasoning and context for how we would make this logic work and turn that into programming, which was able to pull and create this analysis over the course of a few months. And this was so enlightening. This is what it looks like for this group, for the institution. For the first time, validated the people doing the work in being able to show, you can see what I'm doing. It helped build and engender trust. And they've been saying, no, there's something different, fundamentally changing here. The data is pretty remarkable in terms of how much work was happening through this channel. There is no ability to capture, to visualize, to resource the supports. How do we move forward together to make the right thing to do, the easy thing to do, the thing that's part of my work, the thing that's built into my day rather than the stuff on top? That exercise we took on initially was worth every minute that we put into it.
So Dr. Ko, with the work that's been done, is there any interest in publishing this work to help move other hospitals towards more awareness and drive change?
Always interested in publishing and sharing and getting the word out there, and hopefully having others look at their data and say, hey, how is it similar or how might it differ? One of the interesting things that we found was, what is the proportion of our patient medical interactions that come in that are touched, handled, or need a physician or an APP to resolve? We had no great guesses going in. It turns out about 30%. In our health system, inclusive of our network sites, almost 3 million patient medical interactions. If we're looking just at our faculty practices, about 2 million. A third of that is about 600, 700,000. That's the number of patient medical issues. If we consider each one of those an episode of care interaction, and none of that counts as a visit that we're submitting to Vizient for our metrics, none of those are showing up on productivity metrics. That is an enormous amount of hidden work. So one is just the sheer magnitude was surprising. The other part of the message interactions handled by a physician were due to an existing appointment visit versus a net new issue that came up. We deliver care in a clinic and physician-centric way. It's like, come back in 3 months, come back in 6 months. Things will come up when they come up. Patients will have issues and questions and concerns and needs. When they have those, our ability to address them in between those formal visits is absolutely fundamental to practicing good, quality, efficient care and patient-centric care. This channel of interaction is the right care at the right place at the right time for the right issues. That's why I'm incredibly excited about how do we get this right? It's not about how do we reduce as much as we can all of these messages? How do we get rid of them? It's about how do we optimize this channel for the patient, for the provider, for the care team, for the system, and for our institution, everybody. Very similar to how we've done around video visits, what we've done around e-consults. I use this channel all the time to take better care of my patients. I want them to tell me, in 2 weeks, we started this medication. Send me a message and let me know how it's going and if you're having any of these side effects. That's how I look at the potential power of this if we get this right. So that's what's at stake for me. So our cancer service line, a lot lower intensity messages. So they're about 50% with a lot more high intensity messages, sicker patients, you might imagine, more complex issues, more workup and lab work. The high intensity messages are emotional and cognitive burden for our care team members and our physicians. These are the ones that are, I got to pick up the telephone and find out more. This idea of intensity analysis was a way for us to try to understand. That analysis led to a silo and body of work. And now a lot of our teams are building those capabilities and looking at what does that mean in terms of my clinic and my service line.
In my fellowship, we've been talking a lot about access and capacity as a theme. In some of my past roles, I was able to sit in on a lot of multidisciplinary rounds. I've had that firsthand experience seeing certain patient populations being those frequent flyers. The elderly population, chronic disease population. We saw a lot of people with sickle cell diseases coming in and out. I'm curious if you've been seeing trends of certain patient populations that are leaning into portal messaging. Who's staying out of it? Do you think that these patterns, are they improving access? Are they creating almost new divides of leaving some people out of this different level of care?
There's a couple other hats that I wear that are relevant efforts around ambulatory access and also our patient experience. So these are incredibly near and dear to my heart. Yes, we're talking about patient portal messages, but what we're talking about fundamentally is care, a channel of care, access, and broadening the way that we think about and define access. I think about access not as can we get a patient in to a visit slot in a certain amount of time. There are patients who need to be in front of us physically to lay hands on or procedures. There are patients who we need to be interacting with through video visits. All of that is true, and we need to do that when they have a medical need or when they have a preference to come in. All of these things we need to accommodate. There's opportunity for us to broaden the way that we think about access to be inclusive. Can we deliver that reassurance, that triage? Can we deliver our knowledge and expertise through another clinician collaborator to get to that patient? That will set the patient on their diagnostic and treatment journey in an efficient time and place. Those are all forms of access. And when I talk to my patients, that's what's meaningful to them. When what a patient needs and wants, we can deliver that in an effective, efficient, safe, equitable way through different means. That is a journey we are on at Stanford, an expansive way about how do we get access for the patients in the way that they need it, outside and beyond the traditional ways that we measure it.
Absolutely. I love the patient perspective on top of the provider perspective. It's incredible to have this multidisciplinary conversation. You have the numbers, you've quantified this work. What's next? What actions are you taking, insights that you guys are making right now because of this? What is changing?
The concept of being seen and that validation of the work and the care has changed the conversation in the institution and maybe changed the minds and changed some perspectives about this. We're no longer arguing about what is the nature of this work. We're now thinking about access in a more holistic, expansive way, the way forward, as we start to think about how do we take care of populations of patients beyond primary care, an area that we need to dig into more, understanding who and how. They do seem to probably cluster around diseases where we might say there is an active engaged population around diabetes management, or there is an active and engaged patient around skin cancer, early diagnosis and prevention. This is like version 1.0, what was organic from the ground up of what patients started to do and how teams started to use it. What if we were trying to get to a version 2.0, 3.0? What would managing populations of patients with certain diseases or chronic diseases look like? The next thing that comes up is what are billing opportunities? What are ways for us to capture and support the care, the coordination, all of this great stuff that is happening? How do we make it sustainable? And that is the missing piece. Is there an institutional investment? It speaks to the question of who are we leaving out? One of the reasons why we made a decision institutionally not to bill for these messages was we didn't want to impose a barrier from a financial lens that would dissuade people from utilizing this channel appropriately for their care. Because those are the deeper, important questions. Can we do this effectively, safely? And can we do that for all of our patients? How do we make that patient portal accessible to patients for whom English is not their preferred language? How do we help them navigate? How do we present the platform or the information in the language that they do prefer? We are on that journey.
So Dr. Ko, if you could wave a magic wand, what is a change you'd most want to see?
I'd fast forward us 10 years in time, we would be looking at patients with this issue. How are we able to get them to their desired place of health in the most empathetic, connected, engaged way possible? We would recognize the elements of the team members, the clinicians, the care team members, extended care team members, but we would be deploying them in very different ways. We would know which patients to be reaching out to by phone that day, which patients we would be monitoring their data or their remote monitoring for their images. And then the patients who we have coming in, boy, would we know exactly why we had them coming in and what we would be doing with them during their visits. The patient portals would be something that would be part of that arsenal. It would be one piece that we would have figured out how to incorporate into everybody's work.
Dr. Ko, thank you for sharing about a topic often gone unnoticed, helping us rethink how care, access, and value evolve in our digital world. And thank you to our listeners for taking the time to join us today. Please join us for more Knowledge on the Go podcasts. Subscribe today, like us, and send us your comments at picollaboratives@vizientinc.com. And from Vizient's PI Programs team, I'm Mathilde Hanchard, and have a great day.